have to deal with. Okay, so okay, chalo. Subhash, you can share.
Okay, can you see me? Can you see?
Yes.
Can you hear me?
Yes, perfectly.
Okay, good morning, dear friends, on this pleasant Sunday. And in fact, I will talk today on hints at somatization disorder. But before I start, let me tell you that another talk on hints at somatization disorder actually eventually will be given by Sudhir Kothari. This was a talk which he had to give. He has beautiful videos. Somatization cannot be shown or taught without videos. That I can tell you. It is a theatrical performance. And Sudhir has all of those videos. But you know, when, I don't know if you have attended performance of stars, before the actual star comes, there's a small actor who comes on the stage. You know, the big stars finally makes it on the stage. So today I'm like that. I'm just going to whet your appetite for this fascinating journey of somatization disorders. And you just wait for the real talk by Sudhir Kothari sometimes down the line. Now, somatization means when a thought gets somatized, which means there is no real pathological lesion, but patient gets a physical symptom. But the underlying disturbance is a thought disturbance. And the other respectable name for it in the last couple of decades has been somatoform disorders. Somatization is one of the somatoform disorders. So these are disorders which look like physical, but have actually a root in mind or thought. And in fact, there are many names of it. This is the ICD coding by which you get billed. It said these are billable disorders, which is most important thing in America, whether the disorder is billable or not. So somatoform disorder is billable. It has many names: psychophysiological disorder, psychosomatic disorder, somatic symptom disorder, somatoform disorder, and it has a code F45.9. So if a doctor writes F45.9, he can admit these patients, he can bill these patients, and that's what matters in USA. But on the more academic front, the Diagnostic and Statistical Manual of Mental Disorders, which has been getting updated from DSM-1 to 2 to 3 to 4, has basically divided them into these 5 categories with which most of us are familiar. Somatization per se, in which you have got a physical symptom, or pain disorder, or hypochondriasis, or conversion disorder, and less commonly body dysmorphic disorder. These 4, I'm sure as neurologists, you are aware of all these 4, you have diagnosed all these 4. But DSM-5 is the latest, which was introduced a few years ago, and it has simplified these disorders into these 3. And the current nomenclature is these 3 as per the DSM-5. It's basically an old wine in a new bottle, but it puts somatization and pain disorders into somatic system disorders, or what's called SSD. It puts hypochondriosis into illness anxiety disorder, and it puts conversion disorder, with which as neurologists we are mostly familiar, into functional neurological disorder. So now we have 3 kinds of somatoform disorders: complex somatic system, illness anxiety, and functional neurological disorders. And for us, all 3 are important, but as neurologists, mostly we see complex somatic system disorder or functional neurological disorder, about which we are going to discuss further. So first of all, somatic symptom disorder. Now, this is a really, a very good description, diagnostic criteria, in which you can have 1 symptom or 100 symptoms, but at least there should be 1 symptom. You know, previous criteria said you need to have at least 5 symptoms. Now there is nothing like that. 1 symptom is enough, but you can have 100 symptoms which are distressing, which result in significant impairment of activities of daily life, and the person has excessive thoughts, feelings, behaviors. And the most important thing is there's a disproportionate and persistent thought about the seriousness of one's illness. Now, one good thing about this somatic system disorder is that it says a person is worried disproportionately, which means, let us say there's a patient of neck pain. He may be having a C5, C6 disc, but it may not be a significant disc. On examination, there may not be a significant lesion, and yet he is disproportionately thinking about it, disabled about it. It nowhere talks that there should be absence of a physical. There may be some physical lesion also, but it is very minimum. And the anxiety and the symptomatology is quite disproportionate to it. And there's a persistent about it, persistently high level of anxiety. And in fact, they say, when you say that this patient has a systemic symptom disorder, they classify it further with predominant pain and whether it is persistent. It's important for it to be persistent. Otherwise, most of us ourselves have some symptom disorder, but it lasts for 1 day, 2 days, or 1 week. But if it becomes more than 6 months, and if it occupies the person's mind completely, it becomes a somatic symptom disorder. It's very common. As neurologists, you must be seeing it all the time. Now, somatic system disorder does not talk neurology. It cuts across specialties, and neurology is one of them. So what are the specialties which are common? And I'm sure you are seeing them every day. I'm seeing them every day. First one is in the gastroenterology, irritable bowel syndrome. I think every third or fourth person has irritable bowel syndrome. In gynecology, chronic pelvic pain, all tests are normal, but the lady complains of pelvic pain. In rheumatology, fibromyalgia, who come to neurology also. In cardiology, non-cardiac chest pain. In neurology, chronic pain, which you cannot adequately explain, which just refuses to go away with your routine medications. In pulmonology, hyperventilation syndrome. I have myself seen a hyperventilation syndrome, whom I am now following for the last 5 years. Many times he's admitted in ICU also. And the pulmonologist also knows it's a functional disorder, but many times he calls me, says maybe there is something neurological. MRI done several times, everything is normal, and yet he keeps on hyperventilating. And even in infectious disease, following some viral infection and all, for years together you have got fatigue syndrome. And even now the infectious disease specialists do not understand why after a so-called recovered viral infection, they keep on having this fatigue syndrome almost indefinitely. So therefore, I'm sure as neurologists, we see, because most of these, whether it's a cardiologist or pulmonologist or infectious disease or gynecology, they eventually send these patients to us, and we have to take care of them. So therefore, it's important to understand them. And all these are fine examples of somatic symptom disorders. They may be having a little bit of a real thing also, but their anxiety and worry become central in their life. We have to understand that. Now, after that somatic system disorder, the second important disorder as per DSM-5 is illness anxiety disorder. Now, in illness anxiety disorder, you actually may not have the symptoms of a disease. You may not have stomach pain, but you will worry that you have got stomach cancer. You may not have chest pain at all, but you worry that you have got a cardiac disease. So symptoms may or may not be there, but the predominant symptom is the anxiety about the disorder, the fear that you may get a cancer. And so therefore, that is very important. There's a preoccupation, as you say, first diagnostic criteria with having or acquiring a serious disease. Somatic symptoms are not present, or if they are present, they are only mild in nature, but there's a high level of anxiety. And the individual performs excessive health-related behaviors and exhibits maladaptive avoidance. The good thing about it is that there are two types of these illness anxious people. One are care seeking type, who will keep on coming. And second are care avoiding type. They are so afraid of the illness that they will not get a test done. They will not get into an MRI machine. They will not even consult a doctor, but they suffer with the illness anxiety. I'm sure, friends, that you have seen many of these patients. Many of us ourselves suffer from these disorders, because being medically aware, sometimes we get anxious. But the important thing is that if it happens for 1 day, 2 days, 1 week, 2 weeks, it's okay. But when it is persistent and the duration they have written 6 months, when it is going beyond 6 months, then it falls into the rubric of illness anxiety disorder, right? So the first one was systemic somatic disorder. Second is illness anxiety. But the most important one, by which usually we mean somatization, is the functional neurological disorders. We used to call it functional very loosely, but now this is a DSM-5 criteria, functional neurological disorder. It is a specialty in itself. There's a Society of Functional Neurology Disorder, and Sudhir Kothari, I think he's also a member and an expert of this association. And I think he already organized a couple of talks on this. There are international experts on it. This is a fascinating specialty. It is as important a specialty as stroke, as movement disorder. It has the same respectability. And I remember one of my friends liked functional neurology so much that he told me 20 years back, I want to join functional neurology. Isn't there any specialty like that? well, his dream has come true. There is a specialty of functional neurological disorder, because if you treat it, it will be very gratifying. And this is the one which formerly used to be called conversion disorder. So how functional neurology is different from the other somatoform disorders is that it deals with neurological symptoms and it deals with neurological function. So that is neurological function. This is the one which we see often in our OPDs, and people have understood it from the time of Hippocrates. And even at that time, in ancient times, classic times, people have thought of this. And later on in 18th and 19th century, prior to Charcot, people thought, they somehow thought that it has to do something with the sexual frustration. And people were just fixated on that etiology. And that was reinforced by many people. But I think the first time when it received respectability of being a neurological disease was in Charcot's time. Charcot, as you know, was an eminent icon of neurology in France. He first time said that hysteria is a neurological disease, although hysteria derives its origin from hysteros or uterus. So it was thought to be female predominant disease. And somehow still they also thought that it is related to either intercourse or a lack of intercourse, but some kind of sexual abuse, sexual frustration, repression. But Charcot also should be credited to say that he said it is beyond sexual frustration. There may be some other anxieties also. There actually may be lesions, which he called dynamic lesions, which means lesions which are there, which may change. And interestingly, today when we do functional MRI studies, we are seeing something like that. We are seeing some metabolic disturbances which can be reversible, which can be dynamic, which Charcot said. But I think the maximum credit for studying functional neurological disorders, everybody will agree, should go to Charcot, because he, for the first time, classified it, recognized that it is a neurological disease, but for some reason, he also called it hysteria. And he's the one who was the first behavioral therapist, but the behavioral therapy he used was hypnotism. And if you go into the literature, you will find fascinating accounts of Charcot holding classes, teaching about these functional disorders and also treating them. Post-Charcot period, there has not been much development in this field, except in this century, in the last 20 years or so, with the advent of functional MRI and all. I think there's a lot of interesting development. Now, as far as etiology is concerned, by and large, everybody thinks, we are not sure, but everybody thinks there's a repression of unconscious intrapsychic conflict and conversion of anxiety into a physical symptom. Previously, it used to be thought this is mainly a sexual abuse, sexual anxiety, and they try to hide it. Therefore, it's also very cultural specific, and then it manifests. But now we know that it may not only be sexual, other kind of traumas also, trauma of loneliness, trauma of poverty, trauma of broken families also can manifest eventually into this kind of a somatic expression. And the other interesting thing is that there's a learning theory. In the learning theory, they say that many of these children who have these kind of functional disorders have seen their parents or their uncles or their relatives having the same thing. And somehow they adopt this kind of a behavior, because according to them, they think they are getting some kind of a gain from this. This is a learning theory where they have learned it from their own relations. And I think I have seen some examples of that in certain cultures. So therefore, we are aware of this functional neurological disorders since centuries. It has been named different things during different times. Hysteria was the earliest thing. And even in my own lifetime, I have seen respectable physicians saying, oh, I think your daughter has hysteria. In movies, I have seen many times, you have got hysteria. But hysteria basically meant functional neurological disorder. Conversion is a common name in PGH, and they got conversion was a common thing. More sophisticated physicians like my mentor, Dr. Sushil Razdan, would never use those. He would say, this is a non-organic lesion. But basically, mind you, we are talking of the same thing. These are names are different. Another name is functional. And I think that is the most common thing. Although it should be called dysfunctional, but for some reason we call it functional. She is a functional lady. She has no problem. Functional lady. We kind of dismiss it. Although we should not dismiss it. The lesion is, the disease is as distressing as the non-functional one. But this is a name. And then in our Indian style, some of us call it a supratentorial problem. Supratentorial. And the most funny name, which I have seen some physicians calling it upper story. It's an upper story problem. But basically, all of them, there is now only one name, and that is functional neurological disorder. And the prevalence varies from culture to culture. As you can see, women are more prone than men, but men also can get it. Young girls between the age of 10 and 30 are more prone, but anybody can get it. And it has been generally found that it is more common among less educated rural populations, lower socioeconomic groups, particularly where the men are very aggressive, where the men are very repressive, where the men are also given to activities like antisocial activity. In those families, it's more common, probably because of this stress, right? So we have to know this epidemiological fact. Now, what are the hints to somatization? As a doctor, as a neurologist, what are the subtle hints which can make us suspect that this person may be somatizing? So let us go symptom by symptom. Unconsciousness, sudden unconsciousness is a common thing. I'm sure all of you have seen. Usually adolescent young woman. I have seen many times when I was in Srinagar, you know, almost on every casualty, one or two women would be brought hyperventilating, unconscious state with panicky attendants with them. And there are some clues which have been taught to us. One is that if you raise their hand, raise the hand of this unconscious lady, it will not fall on her face. Even if you put their hand or arm on top of their face, they will protect their face. Which means that they are subconscious. They are not totally unconscious. So that they try to protect their face. And if you try to open their eyes, they will forcibly try to keep it shut. They cannot gaze into your eyes. They will steal the gaze. And oftentimes there's a stressor or a trigger in the family, which is kind of a psychologically traumatic event. And then they also respond to painful stimuli. And what we used to do, and I'm talking about 30 years ago, when we had such a patient, and I'm sure all of you will remember the patients you have seen, we would get liquor ammonia at that time. And the moment you would put liquor ammonia over their nostril, they would suddenly wake up. But let me tell you, don't do that. It is not allowed any longer. It robs the patient of his dignity. It's not allowed. So we should not use liquor ammonia. Recently, I had to use Sprit in one of the patients from EMG lab, but even that also should not be used. But this is a stereotypical unconsciousness suddenly. It has a sudden onset, it has a sudden offset, and often keeping the eyes shut, stealing the gaze, and controlling the dropped hand falling from face are important clues which, as a neurologist, we should keep in our mind. I'll tell you one of the cases to show that there can be change from this routine stereotype which I've been taught. This I have seen last year, 25-year-old college student. There was a family stress and she would get recurrent spells of unexplained unresponsiveness. But going away from the stereotype, she would not keep her eyes tightly shut. When I would open her eyes, she would just keep them open and she would give me a hard look into my eyes. And then when I would take her hand and let it fall on her face, she would let it fall on her face. You know, this was very, very different from what I've been taught from the. So many times we have had discussions in which it has been said that those stereotypes have changed, particularly in the educated people. They are called Google generation. This Google generation has read about functional disorders and they make sure that they don't have that. So we have to be aware of that. Also, in fact, when we had this patient, the only one thing which went in favor of her having a functional disorder was that she was kind of indifferent to the environment. Even though she was unconscious, she was indifferent. Even though I sent her home, I was very stressed whether she has really some disease or not. But eventually, over the course of 1 year, I learned she didn't have anything. So you have to be aware of this. Now, second is very common, non-epileptic attack disorder, NEAD. Only other day, we had a very beautiful talk on one of the webinars. This is very common. This is a subject in itself. These are what are called so-called pseudo seizures, but these days people are discouraged from using the word pseudo because it's also thought it belittles the patient. It is an attack. It's a non-epileptic attack disorder. They have asynchronous, semi-purposeful movements. They keep their eyes tightly shut. Unlike epilepsy, try to open it, they will keep it shut. They will respond to your touch intra-ictally also, which you don't expect in a true seizure. And classically, we have been taught they have pelvic thrusting and arched back. They have side-to-side head shaking. I think Roop has given beautiful talk on this before, and now also he has given. They have prolonged attack. It can last for 10 minutes, unlike an epileptic attack, for 15 minutes. And then they suddenly recover, and post-ictal weeping, if it is there, you are sure that it is not a true seizure. In fact, when a patient weeps, the doctor is very relieved. Like when a child weeps after a childbirth, we are very happy. Here also we are very happy if a lady weeps after the attack. So non-epileptic attack disorders, please keep it in mind. Important condition. Now, I have seen, I think only 1 year back, one medical student, friends, who we treated as status epilepticus, and we gave even 5 or 6 drugs, and still he would keep on hitting the. But I work at epilepsy center. Dr. Sita is my colleague, and she only suspected that this may be this may not be a true epilepsy. And the only clue in this patient was, I mean, the seizures actually looks like, particularly these complex partial seizures, no, where you just need to have abnormal behavior. It's very difficult. But the only clue was that the EEG, 24 hours, continuous EEG for several days, did not show a single spike. So that time we thought that this is not a status epilepticus. Because that fellow was a doctor, therefore he knew how to, feign all these epilepsy. And it took us a lot of, I think George Reddy only eventually cured him. He was a 3rd or 4th year medical student, and eventually we tapered him off all the 5-6 anticonvulsants, and now I think he may have passed now, his MBBS. So therefore, it is very important. Here we have clinical thing is important, examination is important, observation is important. About this patient, we thought he was a super refractory epilepticus, but EEG gave a clue here. Now, third somatization disorder is a stroke, what we used to call, functional stroke or a pseudo stroke. Pseudo stroke, as I said, pseudo word never used. Focal neurological deficit. This can be a monoplegia, it can be a stroke. Now, these fellows have a collapsing weakness. And again, here once you ask the patient, if he has got grade 0 power, then you don't have to do it. But if he has got a weakness, then you ask him to outstretch their arm, it will just fall down. It will just fall down like, it will not pronate slowly. Usually if there's a mild weakness, they pronate, but it will not pronate. But most of the features will be same as I showed you in the first examples. They have a non-physiological movement. Even if he's hemiplegic, when you will walk, he will not have a circumduction. He will drag his foot in a most unphysiological way. So therefore, it is very important. It's a good neurologist who can make this diagnosis, because he knows that what is a circumducting gait and what is a dragging gait and what is the difference between them. Then Hoover's sign, Hoover's sign we should know. It may not be present in all, but in many of them, this will be present, because normally when you ask him to raise his normal leg, on the paralyzed leg, unconsciously he will press, and he doesn't know that. So you will pick it at that time, once he will press your hand with his unparalyzed leg also. So this is how we call their bluff, how we trick them into detecting this disease. And important thing in focal neurological deficit of functional nature is there is an inconsistency. When you have residencies, there is some power. When other residencies, there is some power. When you feel, there's an inconsistency across postures. There's an inconsistency between morning and evening and afternoon. And you are more confident when the patient does not have any underlying risk factors, when he is young. So all these things put together, you can suspect. And I'm sure at least the senior ones among you have seen many of these. I remember I have seen many cases, but 2 cases I remember very well. One was a medical student who developed this just a day after her engagement to a boy whom she did not want to marry. She was tremendously stressed. She was a brilliant student. So therefore her stroke actually looked like a real stroke. There was an upgoing plantar also. And those days we did not have an MRI also. Probably CT also was not there. So it really looked like a stroke, except that she was just 22 years old and she recovered completely, and now she's a very big doctor. So this is one case. And second case, I have seen one of the persons remotely connected to me who had suffered a loss in business, and suddenly he was admitted in the hospital with a hemiparesis on one side. I was actually very concerned at that time. We did all the investigations, everything came normal. And then the nurse told me next day that during the night she found that he was moving his arm. In the morning, again, he was unconscious. Now, could this be a factitious disorder? Could it be that he would be malingering? Well, sometimes it is difficult to know that, but majority of the time, they are not even aware of it. It's an unconscious, subconscious kind of a phenomena which makes them do all these kinds of things. And he recovered, and today he is very well settled abroad. So therefore, in fact, in the acute stroke, if you see, I think a sizable number, almost 10% of them, as many as 10% in US who come to emergency are known to have a, not necessarily malingering, but a functional hemiparesis. So it's important one to know. Now, dystonia, you see, functional neurology in movement disorder is a separate specialty itself. And it is very difficult. I can tell you it's very difficult to differentiate a functional movement disorder from a real movement disorder. Mark Hallett and all our big authorities in India, we have big authorities. I think Sudhir is going to show you these. It's a subject in itself, but some things which can differentiate is that there is no sensory trick in these functional patients, which the organic ones have. Second is that there is no overflow dystonia, which is found in the organic dystonias, where a dystonic limb can overflow to the other muscle groups, you know, in the normal one. But here that will not happen. And the one stereotype which has been often described is that these functional dystonia, one is that they may be having a rapid onset. Even if they don't have a rapid onset, this combination of clenched fist and inverted ankle has been thought to be many times associated with this kind of functional dystonia. Not that it can't happen in the true dystonia, it can, but somehow this clenched fist syndrome and inverted ankle syndrome and their combination has been a marker of dystonia. We have to suspect it. But let me again tell you, you may need other things, you know, psychological methods to go deep into their history and neurophysiology and other things. It's very difficult. But there is a high percentage of movement disorders which can be psychological. Tremor, psychological tremor, again, a very important thing. And how you can distinguish it, that if there is absolutely no family history of tremors, if there are no other evidence of extrapyramidal things, and then specifically distractibility. While you are keeping their hands outstretched, talk to them about corona, talk to them about some film and all, and you will see that tremor has disappeared. And the second thing is entrainment. It's a very important method in which you ask the patient, if it is a unilateral tremor, ask him to produce the same tremor from the other side with a different frequency. And you will notice that in the affected hand, also the frequency changes. It's called entrainment. And third is the variability. The rough tremor can become a fine tremor, and the fine tremor can become a rough tremor. And one thing in tremor is that if you load them, if you put something on the hand of a true tremor patient who has a real tremor, that tremor becomes less. Whereas in these functional tremor patients, it becomes more. So all these things we have to see. And sometimes, you know, this functional tremor goes on and on and on, and it is an important thing to make a diagnosis. Sensory functional disorders are common. They have an acral distribution, especially with central facial involvement. And one of the clues which has been often cited is there's a strict midline splitting, as if you have split the sensory loss with a blade on one side, even on the nose also, on the lips also. Half of the lips are totally spared and other half was involved. You have to always differentiate it from a thalamic infarct. So you have to take it in the total picture. But many often there will be thalamic infarct if they are elderly, but in young people, a lot of times, particularly if they are less than 30, it may be just a functional sensory disorder. And they may also come sometimes with tubular or spiral visual field defects. But the thing to catch them is that they are fluctuating. And when you do their visual fields and other things, the patterns which you will get will be quite unphysiological, with which you will suspect that I may be dealing with a functional neurological disorder. These I only gave you some examples, but if you look, this is an article which has come in Green Neurology, you must look into it. It's very interesting on functional neurology. Every motor symptom can be there, every conceivable motor system, involuntary movement, tics, blepharospasm, torticollis, opisthotonus, seizures, abnormal gait, unexplained falling, aesthesia, abasia, paralysis, weakness, aphonia. You know, I have seen aphonias also. So any one of them can be a functional neurological disorders, or what used to be called conversion disorder. So a high suspicion and doing all these techniques and tremendous patience on the part of the doctor is important. Sometimes we have to make sure that we don't get irritated. We have to make sure that we don't get hostile. We have to make sure that we don't get into a conversion disorder, because sometimes we're also human beings. We get frustrated, we become hostile to the patient, we avoid that patient. That is not what we should do at all. We have to be tremendously patient and we'll become a hero. In fact, I once asked Craig Anderson, he's a stroke specialist. I said, Craig, do you have such kind of patients in Australia? He said, yes, we have such patients, and we have one doctor who wants to see only these patients. He gets excited by seeing these patients. So I think we have to be like that. Only then we can solve their problems. So these are the hints to functional neurology in a nutshell. The phenomena which you observe will be little non-physiological. As the example I gave you, stroke patient will not be having circumduction. He will just unphysiologically drag his hand, and his hand will also assume the non-physiological postures. You know, normally you find that the leg is extended and the elbow should be flexed. It may be opposite in that. So a good neurologist can make a diagnosis. If you don't have knowledge of neurology, you cannot diagnose these functional disorders. Then there will be variability and inconsistency from hour to hour, from day to night. Then it may be accentuated in others' presence, but it is not a must. None of them is a must, but these are some clues. Then the most important thing is lobile indifference. Lobile indifference is, it's a poetic term. In fact, lobile indifference means beautiful indifference. I think it was probably Freud probably coined this term. It's like he's indifferent. Even though he's paralyzed, he's smiling. Even though he has got tremor, he's smiling. So this is called lobile indifference. If you have to be sensitive enough to catch it. Say why he's not worried. The attendants will be worried, but the patient is little indifferent. Again, it may not be found in 100% of patients. And then there will be overt or covert stressors. Some stressors may be very obvious, whole family will know, and some stressors may not be known to anybody. Even the patient himself may not be so much in touch with himself. So therefore, that is where you need help of a good psychologist or a psychiatrist who can dig out these latent stressors from his life. Now, differential diagnosis of these functional neurological disorders is factitious disorder. Factitious disorder is a related disorder, but it's a little different, in which a patient wants to have a sick role. He doesn't want to get well, and because he thinks he will get a certain sympathy, and he ever wants to be in the role of a sick man, or he even wants to become sometimes a caregiver of a sick person. It's called factitious. Second is a malingering. Malingering is also a phenomena in which he gets a secondary gain. He may get some insurance policy. He may get an admission into IIT or some other. He may get a job if he shows that he has got, or he may be off from some court case. These are malingering. And third is a dissociative disorder, which is a purely mental disorder in that there is no physical thing. They are fugue states in which a person suddenly feels that she's in a different world. She's in a hotel, she forgets about her credit card, she behaves like a different person, and this is subject of many movies, you can see that. But we have to be aware of these disorders also. Sometimes it is a little difficult to differentiate, but can be differentiated. We have to keep it at the back of our mind. Now, a word of caution, and this is based on my own experience. I have burnt my fingers. Even when you think that your neurology patient is a somatization diagnosis, keep it in your mind. Preferably don't write it on your prescription. You can write the findings, but don't write somatization, because it is possible that eventually this patient may turn out to be something organic and you will be very embarrassed, or the organic disease may develop later. You may have seen him at a somatization state, and tomorrow same person may develop brain tumor and he will show your somatization prescription to somebody. So keep it in your mind, unless you are in America and you have to write F45.9, that's different. So write the findings of the case, but avoid the term somatization on your prescription form. So in summary, friends, somatoform disorder is a spectrum. It's not one disease. It's a spectrum of some kind of a thought disorder, which manifests as a physical disorder, either as a pain or as a symptom, or one of these several neurological syndromes ranging from epilepsy to hemiplegia. And as per DSM-5, they are divided into somatic symptom disorder, illness anxiety disorder, and functional neurological disorder. As neurologists, we'll see functional neurological disorder. There are often some clues in the very remote history or recent history. There are always some behavioral uniquenesses in this patient, and phenomenology. We have to be aware of the phenomenology by which we can catch it, and still we can make mistake in 10 to 20% of patients. But detailed knowledge and experience is essential in a neurologist to suspect and diagnose these conditions. Without knowledge and experience, it is difficult. And management consists of behavioral and pharmacological treatment. Pharmacological treatment does not work that well, but behavioral treatment works very well. Cognitive behavioral therapy is an evidence-based method. See, cognition is a sensory phenomena in what you feel, but behavior is a motor phenomena in which you have to be trained. And that training can be done only by experts who are experts in behavioral therapy, like our psychologists or psychiatrists. One of the names which we should know about these functional neurological disorders is Jean-Martin Charcot. From 1862 to 1893, he worked in Salpêtrière Hospital, Paris, And this is one of the famous pictures which is shown everywhere. He was very good in demonstrating to his students. People used to come from far and wide to attend his classes, where he would demonstrate these patients whom he used to call hysteria, and then he would hypnotize them and he would bring them back. There's a very beautiful book on this which you can buy from Amazon. It's called Performing Neurology. So a lot of neurologists would perform neurology. I myself have had good fortune of being trained by some of them who would show you. I can tell you Dr. Sushil Razdan, Dr. K.S. Mani, Dr. Shamal Sen, I have heard, they would perform a seizure, they would perform a pseudo seizure, they would perform a aphasia. And that is the best way to learn neurology. And I would recommend that you should read this book on performing neurology when you think of somatoform disorders. This is not by Charcot, but it's about Charcot. Thank you very much. And Sudhir, we'll have questions later.
Yes, go ahead. Excellent.
So then I can request my very good friend, Dr. George Reddy, to share his screen. About George, I can tell you, he is our doctor for these somatoform disorders. When we were conceptualizing this program, I could think of nobody other than George. George Reddy is a senior psychiatrist in Hyderabad. He runs his own center called Healthy Brain. He was the president of the vice president of the Telangana chapter of psychiatrists. He is the current president of Private Association of Private Psychiatrists in Hyderabad city. And all our somatoform disorders, whichever we see, they have to go to George Reddy. And I think the success is 100%, not even 90%. So therefore, I requested George that you please come and tell us that how do you manage these patients? How do you get them out of their somatoform things? Over to you, Dr. George Reddy.
Yes, sir. Respected and dear all, very good morning. Thank you, Dr. Subhash Kaul, sir. Thanks for this kind words. And 100%, I should be thankful to you, sir, for the kind of patience you entrusted on me. I think, sir, it was a learning experience. I think you could really present from a psychiatrist point of view. All your slides, I think, I will try to skip and I will try to go to the core part of the treatment. But I'll just take a few minutes to talk about. Sir, am I audible, sir?
Yes, sir. Yes, sir. Yes. You can maybe raise your volume a little bit, at least at my computer, but I can hear you.
Yes, sir. So here, the DSM-5 standard textbook, Kaplan and Sadak, talks about the somatization under the heading psychosomatic medicine. And as Dr. Kaul sir said, and the new term for the somatization or somatoform has been changed to somatic symptom disorder. And there are three subheadings as sir has talked about: somatic symptom disorder, the illness anxiety disorder, and functional neurological symptom disorder. Thanks to DSM-5, I think they're trying to kind of destigmatize these terms like psycho. The word is really stigmatizing, not only in India, but if you look at even the Western countries, the word psycho is more stigmatizing. So thanks to this new terminology, I think it is a way to destigmatize. But for sure, it is a kind of mental illness, and the causes are more bodily symptoms, and many of them include pain and suffering. So when we need to diagnose the component of somatization symptom disorder or illness anxiety disorder or functional neurological symptom disorder, the patient should have bodily symptoms and it should impair his living, and there should be a significant disability, and then I think we should be able to diagnose them, and the criteria is definitely above 6 months, or it should be around at least 6 months. The patient should be having suffering.
George, are you moving your slides? I can't see your slides moving.
Slides not moving.
It's only first slide on my screen. Yeah.
Yeah, now.
Yes, sir. So here, sir, if you really look at the uh, in the presentation, many times these symptoms are masked, and I think as neurologists, you are much better than me. You see all these patients, definitely they mask, and they're mostly present with physical symptoms, and as sir already described, I think no system in the body is spared, no specialty is spared when the patients are presenting with this kind of symptoms. And particularly, we commonly see from the specialties clinics, from neurology, from gastroenterology, from cardiology, and have even patients referred from dermatology, anyway, genitourinary and other branches. The core thing is, thanks to the other specialties, at least when we start to deal with patients, first thing is ruling out physical problem or ruling out the possibility of non-organic. I think that should be the first way to handle. And particularly, I am here in Hyderabad, so I have the luxury to take opinion. But many times, to the psychiatric presentation, they're all many times they are referred from specialty clinics. But even if I see a patient, or if I suspect a probable chance of somatization, I first try a couple of visits, and then if I see that nothing is happening, I make sure that I send to my colleagues for neurology or any specialty, so that I'm sure that I am trying to, at least if not 100%, I'm trying to see that we are not trying to get ultimately landed up in some kind of organic causes. So that, I think, after that, I think it's like we are sure, and we are like kind of confident to handle the issue in a better way. So I think I'll try to skip some of these things next. So here, sir, I think some things which I think Dr. Kaul sir didn't mention. I think if you look at the etiology parts, in all these three subheadings, there are a lot of studies trying to look at the genetic and biological factors, particularly in these kind of patients. And there is definitely a role of the family influence. It could be a genetic or the environmental component. And particularly when there is a negative trait in their personality, and really it can affect their illness and present as bodily symptoms. And many times there is decreased awareness uh, to problems processing emotions. Actually, they look into more physical symptoms and focus on physical part rather than the emotional issues. And it could be, as I mentioned, it could be a part of the learned behavior to either gain something, or to to seek attention, or to sometimes try to avoid some activity. Here, the risk factors for the psychosomatic symptoms, somatization, uh, there could be a high level of anxiety or depression. I think we all commonly see that. And in fact, if we don't rule out the underlying issues related to anxiety, depression, I think we might not get a good outcome. And having a medical condition or recovering from one being at a risk of developing a medical condition, such as having a strong family history of a disease, I think, as sir was mentioning, when they present to us, might be we are looking at somatization, but later on they might land up in serious issues. I think we need to be careful. And experiencing stressful life events, trauma or violence, this could be the risk factors. And having experienced past trauma such as childhood sexual abuse needs to be ruled out. In fact, we have to, it is a sensitive issue where we need to discuss, particularly trying to deal with female population. I think we need to look at this component. And having a lower level of education and socioeconomic status is one reason for a poor prognosis. And I have written some good prognostic factors, which is not in the slide. Uh, People coming from high socioeconomic status, I think it's a good prognosis factor. And treatment responsive anxiety or depression, if the underlying component of anxiety or depression, which is which can be responding to treatment, I think we can get a good outcome. And sudden onset of symptoms can be a good prognostic factor, and we might be able to handle them early. And absence of personality disorder for sure. I think these will be, if you look at the high socioeconomic status, I think at least there could be a level of understanding and connecting with the patients. And I practice at Hyderabad, and I visit the rural clinics every once in a week. Here also I come across patients, but to my experience, I think it takes years for them to reach to a medical professional. And in Indian context, if you really look at, uh, many times these patients, they start their treatment approach first, I think, with these faith healers, and they go about so many people, and they waste their valuable time, and then they go to quacks, particularly in the rural places where they are subjected to so many kind of treatments, and so many even investigations. And by time they come to a qualified physician, a neurophysician or a psychiatrist, I think it takes, for many of them, it takes years also. And just, I think, couple of days back, I had one of my old patients. I think I'll just take 2 minutes on this. The patient presented to me, I think, around 8 years back, referred by a physician. And to my surprise, and I take that as an opportunity, I go through all the records of the patients, the previous treating doctors, the investigations in detail, so that I'm at least sure that I'm trying to deal with a somatization problem. And to my surprise, I have even documented the total number of investigations. I think the battery of investigations were really, I think the CT scan of the pelvis was done, the abdomen was done, I think, around 3 to 4 times. There was 3 to 4 times MRI of the brain. There was CT brain, and the patient presentation was pain in the pelvic region and unexplained. And I think the ultrasound abdomen was done nothing less than 10 to 15 times. And this third time, she had presented again after going through the investigations again. And the reason was she's discontinued my medication and follow because of this COVID crisis. I think 3 months of discontinuation of medication. She presented again, and the test, she was forced by the relatives or family members to come to me, but she was like not willing to come. And if you see clearly, there again they are approached the faith healer, and they had gone to so many things, and ultimately the last physician, and he suspected and said, are you visiting a psychiatrist? Then when they came out the fact that she was under care, he immediately said, you go back to your doctor and try to handle. And I think that's how the patient came back. And if you look at these people, land up in too much of shopping, and ultimately the course becomes a kind of resistant form. And the complications of this illness, poor health, the problems functioning in daily life, including physical disability, problems with relationships, problem at work or unemployment, other mental health disorders such as anxiety, depression, and personality disorders. There is increased suicide risk related to depression. There is underlying financial problems due to excessive health care visits. I commonly see the patients by the caregivers when they usually, when it's chronic, they are fed up because of the cost, the financial burden these patients try to impose on the family due to excessive, visiting hospitals, the ER rooms, and they finally, the expressed emotion in the caregivers becomes a prognostic factor, a poor prognostic factor, because their expressed emotions are all, they are abandoned. They are even many times manhandled, that they are trying to only malinger symptoms without knowing that it is a kind of illness. And again, prevention, very little is possible. And if the patient have problems with anxiety depression, you should seek a professional help as soon as possible, because it's a good prognostic factor. Learn to recognize when stressed and how this affects body, and regularly practice stress management relaxation techniques. If the patient have somatic symptom disorder, get treatment early to help stop symptoms from getting worse and having an impairment in the quality of life. Stick with the treatment plan to help prevent relapses and worsening of symptoms. Actually, here, this is the common thing I notice in my clinics. We do a good amount of homework, we spend good amount of time and trying to deal them. And once they feel that there is some little improvement, they discontinue follow-ups, and wherein it can take sometimes few months to years for a relapse anyway. But many times the course of illness is such that there could be multiple presentations and there could be multiple kind of relapses. I think Sir has emphasized on diagnosis. Again, treatment, the goal of the treatment is to improve the symptoms and the ability to function in daily life. I think really if you look at the management part, I'm trying to talk how I handle my patients. First thing I feel, labeling or putting the patient into a diagnosis quickly, I think we need to avoid. Basically, as Sir said, putting it on paper, there are so many medical legal complications anyway, but keeping it back of your mind and to handle them, I think that would be the best way. And looking at the symptoms, and the goal should be that they function back to normal 100% if possible, should be our treatment goal. And looking at symptom improvement should be our goal rather than the spectrum of the entire illness. So you try to improve symptom by symptom and you improve their quality of life. I think that would give us a better outcome. Psychotherapy is the hallmark of the treatment, and it's called talk therapy, and it can help for somatic symptoms. And sometimes medication also can be added if especially struggling in symptoms of depression or anxiety. The typical way how I handle a patient in a busy day clinic. First thing, when I get a referral from my colleagues, first I just try to spend few minutes, could be 10 to 15 minutes. And when I'm trying to look at the diagnosis is almost sure, I don't try to dispose them off in some little minutes, because they have already been moving around and they're all in distress. So I take the permission from the patient and the family members and ask them to wait until I finish the rest of the patients, because I feel the way to have a successful outcome is, first I have to have time, I have to have a empathetic hearing, and I think at least we need to trying to look at quality time, not less than 30 to 45 minutes listening to them. And so I try to postpone their time and I ask them to wait, or sometimes if they're in a hurry, I don't even start medication, and I try to ask them to continue on whatever they are, and I ask them to make a fresh visit. Because psychotherapy is one of the best way to handle these patients. And there are various forms of psychotherapy, and particularly CBT, cognitive behavioral therapy, can help the improving their physical symptoms. There are other ways of doing psychotherapy. CBT, there is insight-oriented psychotherapy. We can do group therapy, and each one has their own style. But to be frank, to admit, I think in Indian context, we are not very well versed, and we somehow we don't get good encouragement to do group sessions. So ideally, to deal with the patient one-to-one, I think the results are much better. And while doing CBT, the cognitive behavioral therapy, we focus on correcting the distorted thoughts. We try to focus on correcting the unrealistic beliefs, and we try to look at the behaviors that prompt the health. It could be anxiety, it could be it could be depression, or it could be a panic attack, or what all the symptoms are. We try to look at their symptoms through their belief system. So we will try to look at talking to their physical symptoms. We should not try to say that it's all in your head. So many times, at least we try to, we are in a hurry. We want to, dispose the patient, and we say, it's all in your brain. You are perfectly okay. So these kind of things, I think the patient might be showing some kind of, temporary kind of happiness, trying to accept the authoritarian figure being a doctor. But trust me, they are going to leave your clinic just saying that this is another doctor to my list. But I don't think they will go with any kind of happiness, and the doctor shopping would continue. So if you look at doing the psychotherapy, their thoughts are all around. Their thoughts are all centered around physical symptoms. They are occupied that something is there, which I think nobody is able to catch. There are so many tests done, but I have so many patients. If they have even done an MRI of the brain 2 to 3 times, they still wanted it the another third or fourth time. They just feel that at that time the machine was not working, or they were trying to do in a hurry, or they feel that they need a senior doctor, or like they try to find still excuses. So I think we may have to look at their thought process, their distorted thought process about the physical symptoms. How I do is I try to take time to talk about the physiology, and I try to talk about the anatomy. I try to talk about the biochemistry, particularly neurotransmitters. Even if they are uneducated also, we try to put in our local slang language, so that we get connected to them. I think that starts the good doctor, strong doctor-patient relationship. I think that's the key to get these patients into help. And might be we should encourage them that they have to see a single healthcare provider who is experienced in managing this kind of problem, so that we can cut down unnecessary tests and unnecessary treatments also. Because we are doing two things at once. I think we are trying to develop a good liaison, I think a strong relationship, and at the same time we are trying to reduce the family's burden on the cost factor. I think this is my style of doing, because I try to handle both the patient and the caretaker simultaneously. Because it's, again, if I don't try to handle both at once, I think I may not get good results. And I even at the end, I even take time for the caretakers. And in Indian context, particularly where we are burdened, and many come from the low and middle socioeconomic strata to us, I think we are trying to help them both at a time. And learning them to teaching them how to reduce stress, particularly in a busy schedule. I think teaching them Jacobson relaxation techniques, I think it's really literally not possible. But when you take session, I think we can teach them muscle relaxation techniques, or we can even give them simple techniques where they can reduce their stress in terms when there is a kind of revealing kind of stress which the patient can cope in person, or there might be some confidentiality issues also. And we should be able to provide them. Being a psychiatrist, or for me, I know I'm not much into physical medicine, but still, from my little knowledge, or from the knowledge which I've had in the past, I try to help them to talk about, particularly when people come with unresolved headaches, when they come with unresolved GI symptoms, sexual issues. I try to take time and try to talk about how to cope up with these physical symptoms, and simple techniques. Sometimes it might be even many of them know, but again, when it is heard from us, I think it becomes a very good reinforcer for them to follow. And we should take chance to reduce the preoccupation with the symptoms. So I think we should divert them from their physical symptoms. And here I would like to definitely mention, many of times, we are tired in our clinics, we are tired, and when we see this kind of people, I think we try to express that we are tired, or we express that we are already bored, and we are, this is nothing, this is in your brain. I think even our body language uh, uh, tries to, get connected, and we should show that that we are getting connected and we are able to understand their problem. Then I think that's the way we can try to divert them, and they would come back to you again, and then you take up the next level of the session, and the session continues. As many unrealistic or distorted thoughts you feel that they are there in them, you need to give them very good examples, and you need to divert them, particularly when we see people coming from all kinds of economic state. I think we need to be it should be tailor made, so that, like, particularly people are coming from the educated lot, and Google people who Google a lot and come to you. I think we need to follow a different strategy in reducing these beliefs, because how much ever you say, they still try to find. And I see many times patients come secretly with cell phones, they come to record what we say, and then later on they go and they try to find faults. And many times, sometimes what we talk also, something is given on in the internet, I think, which we don't have answers. So these kind of patients also, again, here, trying to bear with them, trying to avoid knocking them down with our words and with our knowledge. I think that can help them to cope, and that is the way where we can develop a good relationship. Reducing avoidance of situations and activities due to uncomfortable physical sensations, improve daily functioning at home, at work, in relationship and social situations, address to depression and other mental health disorders. Family therapy also will be helpful by examining family relationships, improving family support and functioning. Many times we see in the married group who are married, there is definitely a kind of marital discord. There are issues related to uh, the financials thing, and there are many times the extramarital relationship, either of the spouse is having, and many times the role of burden of children's education and the future of the family also. These many times they may not be able to express to their family members. I think only the therapist, I think, could bring out this kind of subtle things in a very open-ended questions, so that they don't try to shed themselves off. And I think we should not add to the other group who shed them off. At least when we are allowing them to open and talk, it might take sessions for sure, but at the end, there is some amount of confidence build up, which can be built in these patients. They go home and at least they're happy that somebody is there to listen to my problem. And the typical way I do is, I don't use this word that you have no problem. I have to say initially that yes, there is a problem which we can address, but I cannot continue to say that you have a problem, because I am again reinforcing negative thing. But initial sessions, we can't use fixed diagnosis, but we can say you have a problem which we can try to settle. As the sessions go on, I think we can start to give them an insight what could be the psychological component in the body, and how it can affect the health, and how it can affect the functioning, and how it can affect the family. So then they start to, and simultaneously with the family. Coming to medication, I think many of us, we look at relief of treatment from the medication part. Definitely, medication has a role, provided we know we are trying to look at least a probable diagnosis. At least we're able to see if there is an anxiety component, there is a milder form, or any kind of moderate severe depression. And many times I have even seen people having traits of OCD, and there's a component of bipolarity there. Medication has to be, we have to be very cautious in using the medication. And commonly used medication we use milder doses of antidepressants. Excuse me. I'm sorry. So milder forms of antidepressants, milder doses, I'm sorry. In the tricyclics, we commonly use amitriptyline, low dose, preferably not exceed 10 milligram, because again, if these people experience any even a single dry mouth kind of side effects, again there's every risk of discontinuing medication. And tricyclic commonly used are amitriptyline and imipramine, and the favorite anxiolytics, I call the antidepressants also the anxiolytics at low doses, but the favorite SSRIs, escitalopram, sertraline, work very well. And in SNRIs, I think venlafaxine, duloxetine, and desvenlafaxine work well. And coming to the anxiolytics per se, using benzos at very low dose possible and with great caution, because I have many of my patients who are addicted to the benzos. We give a brief course, but they go on misusing the medication. But there are these good benzos, particularly clonazepam, on a dose of 0.25 to 0.5, and you can use even 1 milligram when there is insomnia related issues, and lorazepam on low dose, not exceed 2 milligram. Oxazepam has again another promising effect. 10-15 milligrams is really, it does good. And tofisavim is another new molecule which has less addiction potential. And always, if you are sure that the patient is going to follow up better, you can use benzodiazepines cautiously, because to avoid the risk of addiction. But using the antidepressants on low dose, which can work as for depression and anxiety, for longer term might be suggestible. Studies suggest using a trial period of 6 to 9 months. I think at least will help them until they try to cope up, and the problem can be addressed better. And again, keeping the family into confidence, and the follow-ups make things better. And here again, if you look at the course, many times this comes as an episodic. Usually they can last for a few months and sometimes for years. But again, there is these periods are separated by some quiescent periods too. So eventually, at least 1/3 to half of all the patients improve significantly, and the quality of life definitely is better in these patients. And lifestyle and home remedies, while somatic symptom disorder benefits from professional treatment, patient can take some lifestyle and self-care tips, including the work with their care providers, and they should avoid seeking advice from multiple doctors on emergency room visits that can make care more difficult to coordinate and may subject to duplicate testing. I really take time on emphasizing this point, because I talk to the patients and I see that they are sticking on to a trusted doctor, so that they can understand the course better than the multiple physicians trying to handle the problem. Again, practice stress management techniques, relaxation techniques. I think we have to give them definitely this hint that practicing all possible ways of managing stress is mandatory, and everybody has their own ways of relaxation techniques. At least now, yoga and the relaxation meditation has there are a lot of papers presented on international forum. They have good evidence, they're backed by good evidence, and I think it's like we only have to, many patients know that they have to do all this, but again, reinforcing from our end, I think things can make better. And they need to get physically active. So usually I tell patients that as you do little better, see that you're going back to your work. If you're at home, even helping in little housecore activities, that gives them a better mood and they are trying to cope up. And this gives a confidence in their family members too. And they should practice in activities with in work as in social and the family activities. They should not wait until the symptoms are resolved completely. So I tell them very clearly, you can't wait for the kind of recovery that it's 100%. You may not even know that recovery is it is slow and it is progress. It is consistent. So I see that they are back to their lifestyle, and many times people try to use alcohol and recreational drugs to cope up. I really strongly discourage them because it can make things worse, and even at the neurotransmitter level or even in the human relationship. And I convey my warm regards to Dr. Subhash Kaul sir and Dr. Sita Jayalakshmi. Let's collectively fight Corona with courage and hope. Thank you, sir. Thank you.
Thank you. Thank you, George. I think that was very, very insightful lecture, and it will help us in managing our